We're just so thrilled that this worked out, and happy to have you all here, because I know that some of you haven't started on your journey, but and some of you have been through your journey, so there's lots to learn. I want to thank Biote for helping out with the sponsorship. We're thrilled to have you guys on board, and we're going to learn a lot about Biote and hormone optimization. Also, Glenville Medical Concierge Care, thank you for being part of this, Erica and your team. We adore you guys. They are the best doctors in Greenwich. Also to Pray Beauty for the gifty bags, for what's in the gifty bags. Everybody will love this. They have come up with a new line called M, and we are the first people to receive it. So put it on, try the rollers for those hot flashes. They are fantastic. I've been using it all week. I'm like, oh my gosh. So let's see, who else? Roman Empire Farms, CBD. You guys, this brand is phenomenal. I adore these guys. We just got to know each other last week. Everybody needs CBD in their lives. It helps you with sleep, it helps you with calm, and come see them afterwards. We're gonna have a drawing also for 2 prizes, one for a dog and one for a human. So, all righty. Now, I'm going to jump into Dr. Fiona Lovely, who really is my guru. I found her when I was Googling menopause. She is the founder of Not Your Mother's Menopause podcast. I suggest everybody listen to it start to finish. There must be, I don't even know how many episodes, but listen on your walks and or listen in your cars. She hits the nail on the head every time. She's based in Canada. You can get a session with her. She's really phenomenal, because she'll have you do a saliva test, and then she works well with your doctors and with your compounders, and we will meet Rosella shortly. She has really been my guru. She's great to talk to and amazing. She focuses on topics of women's health, hormone balance, and brain function. We will hear from her again at our February event, hopefully live. She's big on brain function and how we work, and also how we age most people are pretty young here, I would say, but she will talk about really how our brain is going to develop as older women. She's been called the Hormone Oracle, the fixer of weird shit, and a disruptor of unhealthy patterns in the body and the mind. Her mission is to share info to empower women and pull back the curtain to reveal the goodness that is possible at midlife. So let's hear from Fiona, and then we're going to jump in with the panel.
Hello, I'm Dr. Fiona Lovely of the Not Your Mother's Menopause podcast, and I'm thrilled to be here to discuss the topic of perimenopause and what to expect with you today. And I just want to thank my friend Elaine from the Fairfield County Look for inviting me to speak with you today. It truly is my pleasure. So, before we dive too deep into this, I would just like to say that there is additional information that you can find out about my work at my website, which is drlovely.com, and you can also find me on Instagram at Dr. Fiona Lovely on Instagram. So fun, right? Okay, so my job here with you today is to demystify, to the best of my ability, the period of time we refer to as menopause. Now, a more appropriate terminology for it is perimenopause, which means around menopause. And because the time when it is the loudest, the symptoms are the most significant for women, is typically when we're still cycling, still having a menstrual bleed. And so that time is called perimenopause. It can start anywhere from 35 to 45 years old, typically, lasting until 55 or even 60 for some women. Now, most women are a sort of 6 to 9 year pattern there where you can start to have some of the symptoms that we know of as menopause. Turns out it's perimenopause. Everything from weight gain, heavy cycles, irregular cycles, skipping periods, lack of libido, sleep changes, mood changes, depression, anxiety, hot flashes, night sweats. There's a lot of things that go along with what we understand to be perimenopause. And medicine hasn't always done such a great job of informing women of what this time means for them. So it's a really good idea for you to educate yourself and become aware of what is involved for some women, not all. And I'll talk about that a little further on here. So the stopping of ovulation and the cessation of reproduction means that you will go without a monthly bleed. And when you have gone 12 months without a bleed, you're considered menopausal. Everything prior to that is considered perimenopause. So, and again, that can start at 35, and it typically starts for women in terms of not being able to elevate our mood or self-regulate our mood like we used to. It's more of a subclinical thyroid and subclinical adrenal problem for women, which of course is often misdiagnosed as chronic fatigue or fibromyalgia or depression or anxiety, and here's a medication for it. But actually, we can really work the levers of lifestyle to manage those symptoms a little better. So essentially all of the systems of the body are involved. It's most likely you will feel greatest in the changes to your menstrual cycle. Again, mood, sleep, libido, appetite. Lots of women talk about weight gain at this time. The dropping off of estrogen and progesterone, which are the primary female hormones, can leave you feeling unable to focus, and they can leave you susceptible to changes in temperature toleration, which is where we think hot flashes are coming from, in that these swings of estrogen up and down are causing the hypothalamus, excuse me, which is the regulating center of the hormones, to give us put the gas pedal on so we get a bit of juice, but in fact we just don't need it. So again, this is a theory. We don't really know why women get hot flashes or hot flushes as they call it in Europe. And by the way, a night sweat is just a hot flash at night when you're in your jammies in your bed. So we don't really know where they come from, but that's what we suspect. So understand this is a totally natural process of the human body, and it's best to respect the rhythms of Mother Nature. But there are things you can do to see that this isn't a bumpy transition for you. And it's really important that a woman embraces balance. And balance is a key determinant of how a woman will pass through the transition of perimenopause. The most important thing we can tend to is stress management. And there is research that shows that is the single most effective treatment for the symptoms of perimenopause, above all else, including HRT, bioidentical or otherwise, is management of stress. So what I will say to you about that is, as we're living through probably the most stressful time we have known as human beings for probably 100 years or close to 100 years, is that we cannot control what happens outside of us, but we can control how we respond to it. And that is the best way to manage stress. Now, it's different for everyone how we achieve that. Maybe it's meditation, maybe it's a massage or a hot bath, or it's a walk in nature or a conversation with a best friend. stress management is different for everyone, but it is the single most important thing that you can do as a woman to control how you progress through the transition of perimenopause. Certainly, get your hormones tested. There are lots of ways to do this. I prefer saliva testing, so your integrative practitioner will be able to help you with that, to take a look and really know what systems need assistance, because there is such a fine balance when it comes to hormones. Now, the primary female hormones are estrogen and progesterone, testosterone as well, although in a much smaller amount. And then other important hormone systems are the adrenal glands, which are the stress management glands. And the way they function is the way, again, like I said, we will progress through stressful times and perimenopause. We need to make sure our adrenals have the organ reserves and the resilience to be able to keep us on our feet and living our best lives. Thyroid gland is also something that shows up for women at perimenopause, and having your thyroid gland tested comprehensively, including testing the anti-thyroid peroxidase or TPO, anti-TPO test, which will give you an idea if you have a hypo-functioning thyroid or an under-functioning thyroid. This will tell you whether it is an autoimmune disorder or not. It's a completely different treatment. So you need to have that tested comprehensively. Certainly you need to prioritize sleep. So important. And as I like to say, your bedroom should be like a cave. It should be dark and quiet. So anything that's in your bedroom that is the opposite of either of those things needs to go. No charging your cell phone on the nightstand. If you read on a tablet, make sure your tablet is off before you go to sleep. Also, turning around or turning off or even taping over your clock, your alarm clock, really important. I know I did this recently and made a huge difference. I didn't think my alarm clock was putting out that much light until I turned it around so I couldn't see it while I was laying in bed. It made a huge difference. Also, curtains and lights from the outside and all of those things need to be looked at. Do you have a partner that keeps you awake at night because of snoring, or are there pets in the bed that are keeping you awake? All those things can be managed. Sleep prioritized is one of the best things we can do for stress management, as is movement. Now, in previous iterations, we would have called this exercise, but there's too much emotional baggage that goes with that word exercise. So look at it like, are there certain things you like to do with the movement of your physical body that make you feel good? In which case, do it and do it often. I love to dance. I love to walk in nature. I enjoy yoga very much. Those are the things for me that are really important. So find a form of movement that you love and do it more. Managing your mental health is a really important factor in perimenopause. And I'd just like to say the best way to look at it is think of self-care like self-practice, as in what are the things that you enjoy the most and how can you do more of them? I made myself a list, certainly during the shutdown last year where I wasn't feeling great. I made a list of things I love to do that bring me pleasure, that bring me joy immediately, and I regularly refer to that list. So I'm going to encourage you to do that. Please don't look at it like a to-do list, because that's the last thing women need, is another thing on our to-do list. But look at it as how I can act in order to be my best self. Now, I mentioned nutrition earlier, and it's a really important thing to embrace, is looking at your food and saying, am I eating things that are going to set me up for best case scenario, for providing my body all the nutrient it needs to create the hormones, to create the balance, to create the sleep and wellness neurotransmitters that I need. There's a lot of non-foods out there we consume, like diet pop. There's a lot of that out there. 0 calories or negative nutrition. And I'm just going to encourage you to stay away from it. Now is not the time. However, we're all humans, and the 80-20 rule works really, really well. That means 80% of the time, do your very best. The 20% of the time that you don't, it's not going to make that big a deal. And sometimes it's just good for the soul. For me, I like cream and sugar in my coffee. I have one coffee a day. I call it a ritual. End of the day. End of the deal. I do not pursue it throughout the day. It's really about balance. Nature soothes us and nourishes us. So if you get a chance to walk in nature, do it. Even if it's too cold, I'm here in Western Canada, so we get plenty cold up here. If it means turning on the sounds of nature while you're warm in your house, not the best, but it'll do if it has to. And finally, I want you to find a community, a sisterhood, if you will, to support you and help you thrive. Because women heal women, and we do it in groups, just as this beautiful group meeting today is. I love this idea. So I'm actually embracing this in my own work right now and working to bring together women in community so that we can heal each other. It's important that you educate yourself so you know what to expect of these years. And again, record a list of activities that you can do to return to a moment of peace. Self-practice. Think of it as self-practice. Self-care is fine too, but that word's been kicking around long enough that we've made it something on our to-do list, and that's not the point. The point is to stay balanced. Know your psychology. For sure, the menopausal transition as a way of making you feel like you're losing your mind. I know I've had plenty of times where I felt like oh my God, am I crazy? Like, is this the best? Is this the best it's going to be? You're not losing your mind. The egress of hormones can make you feel like you're crazy making. Again, see your integrative or functional medicine practitioner to have your hormones tested. And look at your food. What's your intake? Food is a really important medicine. Let your family and loved ones know what's going on and have good supports in place for this. You will get through this. Many, many women go through menopause with peace and ease with the correct preparations, and this can be you too. So I wish I could be there today to be with you in person. However, that was just not to be. So I hope this has brought you a little bit of an overview, if you will, of the transition of perimenopause. And I would love to speak to you. Whatever questions you have, go ahead and find me on social media and send me a message. I'm happy to answer for you. So enjoy the other speakers today. Thank you for listening, and take care of yourselves and each other.
Amazing overview by Fiona. And now for our panel. Patty Carneglia, come on up. You're our moderator today. Patty is with BioT, and she is their regional manager of the Northeast region. She has been in the medical industry for over 30 years in management roles. Marketing and sales and business development, which we know she's phenomenal. I feel like this has been such an awakening for me with all these new friends. And she loves to focus on aesthetics and women's health. All righty. Now, Dr. Erica Kraus is with the Glenville Medical Concierge Care in Greenwich and an attending physician at Greenwich and White Plains Hospital. She earned her Doctor of Osteopathy at New York College of Osteopathic Medicine, where she graduated with honors and completed her internship and residency at St. Vincent's Hospital and Medical Center in New York. Erica takes a holistic approach to disease prevention, including in-depth exploration of a patient's gut health, hormones, inflammation, stress levels, nutrigenomics, and other factors impacting wellness. So please join us. And last but not least, Rosella Menta is a pharmacist who specializes in bioidentical hormone therapy at the Rye Beach Pharmacy. She graduated from St. John's University. Rosella is a mother of 5 children, and having a great career, realized she wanted to make a difference in the field of pharmacy. Her passion is to meet with patients face-to-face and help them change their lifestyle by educating them about their concerns. Working with a patient's doctor, Rosella can help make a plan that will fulfill the patient's needs. The most rewarding part of what Rosella does is to monitor a patient's progress and guide them to achieving a better road to health. There is no greater joy than to see a smiling face and having a patient thank her for changing their life for the better. Here you are.
Yeah, sure. Thank you. So do we have a formal presentation, or would you like us just kind of?
Just jump right in.
Okay, wonderful. So first of all, ladies, thank you so much for being here today. I like to start off by saying you can have all the money in the world, but if your health isn't good, what's the point, right? You can look fantastic. I come from the world of aesthetics, and it wasn't until I really started with women's issues. My last job, I worked in vaginal rejuvenation. Can you imagine what that luncheon looked like, right? Yeah. Did about 300 of these patient seminars, but the one thing that we all found in common is we all experience these things and we think it's our fault, and we think that our body is not cooperating with us and we don't understand why. But I want to tell you that these things happen to everyone. So I'm 57. I'm fully in menopause. I was talking to both Dr. Krause and Rosella in the beginning by saying that when I first started on my journey with hormonal optimization, I really struggled. So I was about 50, 51, and I was having all kinds of symptoms, including vaginal dryness, low libido, couldn't sleep at night, I was moody. My husband just loved that. It was a real struggle for us. He's a wonderful man, thank God, for putting up with me during that time frame, but I literally tried everything. Patches, creams, pills, troches, you name it, and I was really struggling the whole time. So I'm from BioT, I work at BioT, and I'm really happy to be with this company. What we do is we train physicians on hormone optimization, specifically testosterone and estradiol. Women make more testosterone than they do estrogen naturally. And a lot of women don't know that. I didn't know that before I started with BioT. So we train our physicians nationally. We have about 5,000 providers nationally on how to optimize hormones, because we lose them at a very early age, including testosterone and estrogen. It's part of the reasons why we're tired. We don't have as much stamina. We all have kids. And how hard is it, right, to manage your kids and their lifestyle, especially through COVID? What challenges women had during COVID when their kids couldn't go to school? Wasn't that the crisis of the century, right? Very difficult. So for us, it's been really nice to be able to train our providers in optimizing hormones and having women and men, by the way, feel very good. And our whole goal is to have everyone age healthier and live happier lives. Because what's the point to age and feel terrible or have things like Alzheimer's or breast cancer or those types of things as we age as well? So we do this, we train our providers, and we apply testosterone and estrogen in the form of a pellet that's inserted under the skin. That's nice because for women that lasts about 3 to 4 months, and for men that lasts about 5 to 6 months. And we have about 60% women and 40% men that get pelleted every year, every month, every quarter, and have great results with it as well. So we're just very excited to open up the conversation about that, and also to host these beautiful women about what they do as well. So I'm here and was asked to moderate, and I'm actually here as your advocate because I know what it's like to sit in an audience and feel like I have all these symptoms, but I'm nervous about talking about it. I'm uncomfortable, and I feel weird even being here and bringing it up. So we just want to make sure that you all understand it's okay, you're in a safe place, and we really want you to feel comfortable asking questions and talking about those symptoms and those things that are bothering you. So, yeah, Dr. Krause, if you'd like to speak a little bit about, what you experience with your patients and what you see frequently.
So, hi everyone. This is great. It's great to be here, and I like what Dr. Lovely said about a community of women, because that's kind of what this is. It's just a big group of women talking about ourselves and menopause specifically. So just to tell you a little bit about who I am, I'm an internist. I was in a private practice in Pelham for 12 years in New York, and then when nobody could really be in private practice for themselves anymore, it was getting very difficult, and all the big groups were coming and buying up practices. That's what I did, and I went over to WestMed in New Rochelle, and I was there for 9 years, and then just got to a point, probably coinciding with my going through menopause, where I just had enough and said, I'm not gonna, I just can't practice this way anymore. I can't see 20 patients and spend the 20 minutes per patient and move on to the next one. And it didn't feel right. So I came to Glenville, and I joined a great group, Glenville Medical, and there it's a concierge practice, which means we have a lot more time per patient. So I went down from about 3,000 patients to just a few hundred patients, so that I have a lot more time to spend with patients. And I can do more of what I love, which is the integrative medicine and functional medicine. I do conventional medicine too, so I kind of do it all. But for today, just talking about menopause, I just want to kind of go through some of the symptoms, which Dr. Lovely did talk about, just to go through them a little bit more, the common symptoms. So basically, we start out, and we are, between puberty and menopause, our hormones are just up and down all the time. So they're kind of all over the place. But they start kind of trending down as we get into perimenopause. And then one of two things can happen. Either they can kind of keep trending down until you hit menopause, and then they're a lot lower. Or for some women, they kind of plummet. And so they go from, you have your estrogen and your progesterone and testosterone, and then all of a sudden things really drop off. And often that's when people really feel horrible, and that's when they come in and they're like, what's going on? I'm moody, I'm crazy, I'm having dryness, and all these symptoms. Sometimes if we check blood around that time when it starts, everything looks kind of okay. And it's like, well, you're not really in menopause yet. You may have some time. And then we can check it 2 months later, and they're completely, you see estrogen down and progesterone down. So it doesn't really follow this very nice. It's hard sometimes to tell where women are just by the numbers at that point. Men, it's very different. Men can go through andropause. Not all of them do, but they can drop. Their testosterone levels do get lower too, but it's a much more gradual change for them, so they don't tend to have as much of the issues as women have. It's definitely harder for us. So I'll just go through some of the symptoms, and then I'll just go through what we do to help them. But sleep is definitely a huge issue with menopause. And as an internist, I'm always going to think about it from a more I want to look at everything, and I'm thinking, okay, if this person's not sleeping, is it menopause and hot flashes, or is there something else going on? So we know sleep apnea is a big cause of difficulty sleeping, where people kind of stop breathing for a few seconds, maybe 30 seconds or so, and that can definitely interfere with sleep. And that's usually associated with snoring, waking up frequently, being tired during the day. So I'll always want to ask about that and make sure it's not sleep apnea, and I'm not just assuming it's menopause. But yeah, definitely menopause, night sweats, and hot flashes can cause those troubles sleeping. Mood swings are huge. So Dr. Lovely talked about that too. The anger, the depression, anxiety, rage, and then sometimes just that, it's almost like that pregnancy brain where you just can't think, or I can't think of a name, I can't remember it. And a lot of women will think maybe it's starting early Alzheimer's, what's going on with me? But usually, if this is happening around menopause, that's usually what's causing it. And then there's also decrease in libido, which happens to many women, but not all. Sometimes this can be due to the vaginal dryness, because if there's dryness and there's pain, you're not going to be interested in having sex, of course. But testosterone is one of the hormones that's really responsible for libido in a lot of ways. And that doesn't always drop off, because that testosterone is made in your ovaries and your adrenal glands. So sometimes the adrenal glands are still producing enough testosterone that people don't really have that issue. There's also something called the genitourinary syndrome, which is basically the dryness and then also urethral discomfort. Many women will get urinary tract infections, and that happens more around menopause. Weight gain, definitely. Weight gain around the middle where we don't want weight gain, and that's a function of lower estrogen. Muscle tone, get loss of muscle tone. People talk about the crepey arms and like what happened to my arms. They weren't like this before. Bone loss, osteoporosis, joint pain. Also, women will wake up at night and they'll, they wake up in the morning and they're achy and their muscles hurt. And hair loss too. A lot of women will experience hair loss. Usually for females, it's kind of around the crown of the head, that pattern, like thinning, noticing the part is getting bigger. So I know this all sounds wonderful, and you're all like, if you're, oh, and by the way, this goes on for about 7.5 years average, so that's not great. So you're probably thinking, if you're not there yet, what can you do to kind of help yourself now to make it easier then? And I think the stress management is so important. I definitely think kind of getting your stress under control before you get to the point where you're really struggling. So whatever it takes, if it's yoga, meditation, make sure you get out and exercise, get together with your friends, community, social, do things that you love to do. That's really important. Healthy eating too, definitely can't be understated. Sugar, I think just if I had to put one thing up there at the top of the list to avoid, it would be sugar. I mean, sugar just causes, creates inflammation in our body. It causes obviously weight gain, there's links to cancer. Not only, you think of diabetes, but also hypertension, high blood pressure is related to too much sugar. And then exercise and making sure that you are exercising regularly and not only doing sort of cardio exercise, but strength training is really important too because of that muscle mass that happens. So treatment, what can we do for these things? So hot flashes, I'm going to talk a little about hormones after, but other things that we can do for the hot flashes. So there's like a few supplements that can help. There's black cohosh. For years we've been using black cohosh. I think sometimes women need high doses of that. Sometimes they come in like 20 milligram pills, and we really need probably more like 80 milligrams for a lot of people. There's also something called Repontic rhubarb, which I think is a little bit better. And I just noticed recently that Estroven, which is sort of the big commercial supplement for menopause, they just reformulated it, and their main formula, it's called like multi-system menopause support, is now Repontic rhubarb, where they used to have black cohosh was their main ingredient. I think they realized that it works better, which I think it does, but it does take about 90 days for it to start kicking in. There's another product by Metagenics called Estrovera that I like that also has that Repontic rhubarb. For sleep, make sure that your room is cool. Your husband might not love it, the room being like 50 degrees, but to keep it cool. There's also something that I like called a chili sleep, and they make a product, one called chili sleep and one's called Ooler. It's like cooler without a C, and it's a little pad that you put under the mattress, and you can control the temperature. So on an app on your phone, like I have one, and I love it. I put it to 68 degrees. You can have one for the whole bed or just half the bed. I have one that's like twin size, so my husband doesn't have to be freezing, but it's like having a little air conditioner right under your sheets, which is really nice. Stay away from the blue light, so keep your phone, don't look at your phone before bed. Blue light blockers, those glasses, those are good also if you do have to be on your phone. And avoid alcohol. I know we think, I'll get a good night's sleep, I just have a glass of wine, but it may help you fall asleep, but it's going to prevent you from getting into that deep, slow wave sleep that we need. And then there are some supplements that are good too for sleep, like magnesium. And I love magnesium, but you really want to have what's called a chelated magnesium. So there's one called magnesium threonate. It's like THREONATE. And that crosses the blood-brain barrier. So that really can help sort of calm you. Like you don't want to do sort of like the more common magnesium brands are like magnesium sulfate, and that kind of just goes right through you. That's good if you're constipated, but for really, absorbing it, that's not going to work that well. Something called GABA. Oh, did you? Yep, magnesium threonate. It's THREONATE. And then there's GABA. And GABA is kind of like a natural Valium, and that can be really helpful too. For some people, it doesn't work for everyone. It also needs to cross the blood-brain barrier, and some people have almost like too much of a barrier. Well, it's actually, you should have that barrier, but if you don't have as much of that barrier, then it can kind of cross, and that can help to relax people. There's also an amino acid called L-theanine that I like, Theanine. You like that one?
Every day.
Yeah, that one's really helpful too for sleep. And then 5-HTP, which is like a precursor to serotonin, and that helps too. And sometimes there's these formulas, and Rosella, I know they have them at Rye Beach. They sell
we
a lot
have
of those.
at least 150 lines of vitamins and supplements.
Yeah, and they're good pharmaceutical grade ones that you guys have. So then for the bones, make sure you do get a bone density. This is a good time to get one around menopause to see if you do have osteoporosis or osteopenia, see where you are with that. Exercise, again, really important, bone-bearing exercise, weight-bearing exercises. So even walking is weight-bearing, jogging, lifting weights, that's very important. For treating that, if you have osteopenia, there's a lot of really good supplements that are just like bone building supplements. We always think of calcium and vitamin D, but there's magnesium should be in there, and manganese and boron and vitamin K that kind of delivers the calcium to your bones and not to your blood vessels where you don't want it. So there's a lot of them. And they really work. Like I'll have people take those supplements, and then a year later we'll repeat the bone density, and I'll see an increase in the bone density. There are medications too, bisphosphonates, which is like Fosamax or Prolia, which just if you have osteoporosis, I wouldn't use them if it's just osteopenia, but just to know that after about 3 years, they can cause these what are called atypical fractures in the bone. So you should only be on them for 5 years and then really come off of them at that point. For the libido, the hormones, and the North American Menopause Society just recently endorsed testosterone treatment so it's like approved now for menopause. The only problem is that there is no commercially available testosterone right now for women, only for men. So that you would really have to get, it's not a problem, but you would want to have your testosterone compounded. And and there's also other treatments, which Rosella will talk about for libido.
Different dosages and different, right, I will.
And different stuff, yeah.
Yeah.
So hormones. So the big question that everybody has, is it safe, right? Everybody is just like, okay, should I take them? Should I not? What's the deal? So decades ago, it was believed to be safe, and everybody, everyone was fine with hormones, and we knew that as long as you had a progesterone with it, it's going to prevent the uterine lining from building up too much, help prevent uterine cancer. And then in 1993, this big study came out, this Women's Health Initiative. And from there, they said, okay, wait a second, these hormones are not good. Now we see that they're increasing the risk of breast cancer and strokes and heart disease and blood clots. Everybody should, come off of your hormones. So then years later, they kind of went back and looked at the study and found that there's a lot of problems with the studies, looked at the data again, and saw that that wasn't really quite the case. Also, there's a lot of differences in the types of hormones that you're taking, whether it's oral, whether it's a cream or a pellet, and those differences can impact the effects and the safety when you start the hormones. If you start them soon after menopause, within the first 10 years, or are you starting them after 10 years, that there's differences in safety with that as well. Probably better to start it earlier after menopause. So looking at it more closely, most experts now say, you know what, for these hormones there may be some risk. There may be some risks of clotting, more so with oral estrogen than the creams or other formulations. But the risk is very small. And for symptom relief, women having all these symptoms and knowing that the hormones really do help, and that it's worth it. And it was really, I think, a disservice to women to just kind of say, nope, nobody can take their hormones anymore. People do feel much better, in my experience, when hormones are needed. So I'm always looking, again, as an internist, I look at the whole body. I don't like oral estrogen because it does go through the liver. It's heavily processed by the liver. And that's, why have something go through your liver? Your liver is, you need it for everything else if you can avoid it.
And also, you shouldn't drink alcohol if you're having oral estrogen, because that could interfere too and cause a lot of side effects.
Yeah. and there's more risks of the blood clots on the oral estrogen. So for a lot of reasons, we don't use that. Progesterone orally is not it is not the same. I mean, that's okay. You can do it. It doesn't go through the liver as much. And for a lot of women, help with sleep. So they'll take an oral estrogen at night, and a lot of times we'll compound like a cream, estrogen, testosterone. So I think for symptom relief that it definitely helps. And just to also say that I know this all sounds scary and bad, but I think menopause can also be a good time. Like for me, it was what got me to do what I finally wanted to do. And I think we kind of get wiser at this time. We spend more time, on ourselves, and I think it's not all bad. I think it can be great. So I think that's, and just one more thing about the hormones. Important to really, it is important to monitor your blood or saliva or urine. I often use a urine test. It's called the Dutch test. It's that looks at dried urine test for comprehensive hormones, it stands for. And if you're on hormones, you really do need to get them monitored, make sure that you're not too high on any of the hormones. You also need to do a mammogram every year, which every woman should anyway. I like breast sonograms too, maybe a transvaginal sonogram also, that is a good idea.
Great, that was perfect. So Dr. Erica Kraus is my doctor. I actually have been on her journey from where she was in New Rochelle on her own, then Westmed, and now she's concierge. She's very thorough. I really enjoy working with her and being her patient. With that said,
Rosella?
You're welcome. I didn't even know we were going to speak together. So when we found out, I was like, this is really cool. So I was happy about that. So I work for Rye Beach Pharmacy. I'm a compounder. I am a hormone specialist. I got my training through PCCA. They're the Professional Compounding Centers of America, and there are doctors on board. There's also some pharmacists and consultants, and if there's any question about any compound, we refer to them. They do lots of studies. They're FDA approved, manufacturing, and we get all our powders and all our devices from PCCA and some other companies too, but they're our main one. And so every 2 years, I go for CE credits, and I visit all the different areas of compounding, so I learn more about the bioidentical. I do work with doctors that are not in the know of hormones, so I help their patients with hormone replacement. So it's like a triad: pharmacist, doctor, and patient, and we work together to figure out a dose individualized for that patient. But there are other doctors that are in the know, and of course they could prescribe and then send to us the prescriptions. So Rye Beach Pharmacy has been in business for at least 65 years or so, and there are 2 levels. There's the first floor, which is basically just retail, and they also sell home health care, lots of supplements. We have a pharmacist that specializes in supplements there as well. And then we also have some really great gifts, and that's why I tend to close my eyes when I get in there and go upstairs. I'm like, I'm not buying it. So I work on the second floor, and I have my own office, and that's when I see patients. And when I don't see patients, I help out in the lab, and then I help lots of women that have questions. They're like, I saw my doctor, and I don't know, what is this for again? And I'm like, okay, gotcha. So I help them out with that as well. As far as the compounding goes, I did get my training again through PCCA, and I went to St. John's University, graduated. I have a BS in pharmacy, and I also market to many doctors, teach them about compounding. So compounding is the art. It's a science. It's actually mixing ingredients together. It could be some inactive ingredients and some active ingredients, and then we figure out a formula that best suits the patients. It's fun. It's like a recipe in baking, similar to that. Once a patient decides what they want, then the doctor would prescribe it. So I work together with the doctor on that. So we have different dosage forms, and basically if let's say there's a product that's no longer commercially available, or if there's a product that's on back order, we can source it for the patient as a powder and make the compound for them if available. So it's pretty neat that we can actually help certain patients. Patients that are allergic to fillers, binders, in the commercially available products, we can also compound that, so that can help those type of patients. And we do have different dosage forms, capsules, that we make for patients. We can do either immediate release, suspended release, and it's all very hypoallergenic inert ingredients that are in there. And so other different types of capsules would be like, for instance, like progesterone's available commercially as Prometrium. It's in a peanut base. A lot of people have allergies to it. So we make a progesterone that doesn't have peanut oil, and it has other ingredients that will help prevent side effects from progesterone orally in that manner. Another dosage form we have is creams, topicals, transdermals. So we could, and it's pretty neat because we can mix estrogen with testosterone for formulations for patients. So it's like pretty easy to use just one cream. And then we have lozenges for patients that do not want to use a cream. It's like, I'm too busy, I'm working out, I have all these animals, I don't want to apply a cream, can I have something that I could take? So I do not like oral. However, if the patient understands how to take the lozenge under the tongue or buccally, it'll get into the bloodstream, do its job. Not my preferred way of getting the hormones, but we do offer that as well. And then we have suppositories and many other things. But again, like we can make even for pediatrics, if, for instance, they are allergic to certain products or if they can't swallow, we can use suppositories in all different types of dosage forms. Let's see what else that I wanted to address. Also, what I love to do is work with doctors about, let's say, libido products. And so we kind of figure out formulas of creams that women could apply to the clitoris to get them feeling sexual, or they can use oxytocin because that works on the neurotransmitter to help you feel good and, you know, and also bond to your person that you're with. And so even anti-aging creams, we can like figure out different things that we can add to it. It's like, what do I do for my wrinkles? It's like, let me think, let's figure something out. So we have the different formulas for that too. So I think that's about it. I think I covered most of it.
Yeah,
Yeah.
that was nice. Ladies, you have to have some questions for the panel up here. And don't be shy, because if you think you have a question, there's probably everyone else who has that same question is afraid to raise their hand.
So what's the average time span that women are on hormonal replacement therapy? Or what's the safest, and what shouldn't they exceed?
I think we still don't know for sure the answer to that. There will, you'll hear different things. You'll hear the shortest time that you need just to control your symptoms. I think that the jury's still out with that, but I think we do know starting them, the sooner you start it after menopause, the better. And so you do have that year of no period in order to be in menopause. So you're going to have, a year probably where you don't go on the hormones. But starting it after that is probably best. And then, I have women who, I have like a 70-something-year-old who still is on hormones, and she feels great, and she looks great, and she's doing great with it. So I don't, and she's like, you're not taking my hormones away, so I won't, and she's okay. So I think it really varies by the person. Some people just get to a point where they're like, I just don't need it anymore. You kind of, because it's that 7.5 years average where you're feeling those symptoms, and then some people don't feel them anymore and want to stop it after that. But it is, as far as like the bones, it really is kind of probably the best thing you can do for your bones, even more so than the other medications. So.
Yeah.
Sorry.
I just was going to add to that because you're absolutely correct. But if you think about it, we lose testosterone and estrogen, and we don't make it anymore. So truly, if you remove it, you're probably going to have the symptoms that you had before. So this is really a lifetime journey, and there's some very interesting science that's out now. We just published a study 3 months ago that showed by using our pellets, both testosterone and estrogen in pellet form, we did a retrospective study over the last 9 years, and we were able to show that we were able to decrease breast cancer by 35.5%. Very significant, and that was just recently published. So hormone optimization and balancing is extremely important, and it's not something to be overlooked. And it's funny, I think women think we go into menopause and we're post-menopause and we come out of it. We're not making hormones for the rest of our lives. So we go into menopause, but that's not an opening or revolving door that opens on the other side. We're in menopause forever. It's how we manage it through the rest of our life. So just it's important to know.
Well, what's
Lots of
important
questions.
too, you're right. No, what's important too is that the commercially available products are really strictly for hot flashes and night sweats, period. It's not about like, okay, for, well, bone strength as well, but about like looking better, feeling better, brain health. I mean, there's so many good, positive things to take hormones for. So 5 years, I'm sorry, is not enough. It's got to be for the rest of your life, honestly. And as long as you're being monitored, then that's really all there is to it.
Yeah. Testosterone's impact on all the organ systems, if you think about it, testosterone is anti-inflammatory, it's a vasodilator, it brings blood to all of your organs. So it's extremely important that that's part of what you have in your system at all times. Our providers have been able to reverse osteopenia. It's just incredible what's happening for women. And if you think about it, with blood flow and reducing inflammation, we do reduce plaques. And plaque is evident in our brain, beta amyloids, in terms of dementia, and in terms of cardiovascular health. The more we can reduce inflammation and the plaque that builds up there, it's really important. And testosterone is really important to that. And we did just, for BioT, there is a book in all of your bags. It's called Testosterone Matters More. It's Dr. Gary Donovet's book, and he talks about testosterone and all the organ functions and the body systems that it affects. So I would encourage all of you to read that as well. Has all the latest science in it, too.
I'm excited.
I'm just a little bit confused. So when do you start the hormones? What's perimenopausal? What's during menopause? And then is all of this started after your year of not having your period, or does this all happen when you're, spotty, like you get your period every 3 months or something? I just don't know when all this is supposed to start.
Well, what I do is I generally, so during that perimenopause where you're still spotting and bleeding, you can start, if you're really feeling symptomatic at that time, sometimes we'll check the hormone levels, and you might start, sometimes I'll start a little progesterone because that can go down. Usually women still have estrogen, and you don't really want to do estrogen while you're still cycling, but sometimes I'll start a little progesterone because when that drops, people get their symptoms, sometimes a little testosterone maybe. But usually it is that after that year where you really start, doing, that's what I do. I think there are some providers who will start before that, but generally it's after. I don't know if you see different with yours.
Yeah, I know there's a lot of different ways to look at it. And in our providers, what we do is we treat the symptoms, because we have women that have symptoms, in their early 30s. We have young men that have really low testosterone in their late 20s. So we treat people all the way from their late 20s all the way through. Our oldest patient is 97 right now, and they're doing beautifully. So it's just a different look and a different view and a different paradigm about hormones and how they affect us.
Well, I agree with you on that because I work with so many different doctors and they have their own way of dosing. So there's all different modalities. It's got to be what's right for you, what fits you, that's going to be the driving force.
And I think all of us up here really believe in individualized medicine because, you're not the same as I am. You're not the same as I am. We get a very different dose of our hormones, as well as I'm sure you treat thyroid, and we look at nutraceuticals and lifestyle and what you're eating as well. But I really think that if your hormones are not optimized, you're starting, kind of fighting with your hands tied behind your back. So as a company, for us, BioT, we treat symptoms, not just the labs alone. We ask the patients, how are you feeling? Because if you're still having symptoms, you probably still need to be further optimized. So we do both. Yes, go ahead.
I was wondering if you've heard of a tubal ligation starting menopause.
It can. Not typically. It shouldn't. But, you are affecting the blood flow to the ovaries a little, so it's possible that it could do that. Is that what happened? It shouldn't. It's not supposed to. It shouldn't be. Women often have that, right after their, a pregnancy, so that would be hard. But I haven't seen that. I've seen with hysterectomies, but I haven't seen it after a tubal. Just hysterectomy, just the uterus. They shouldn't go into menopause because they still have ovaries, but I have seen that. For me, it varies with a person. I'll check it usually a few months after starting, usually about 3 months after starting to see where they are. And then if things are good, I don't check that often if we're on the same dose and they're feeling great. So I might check, another 6 months, and then if it's good, like a year. So I don't do them too often. I don't know if you guys have a different protocol.
We're the same. We're doing at least a couple months, making sure the patient's doing well, if not 6 months, and then it's yearly from then on. Yeah.
I think everyone's sort of gun shy when it comes to hormones. Like most doctors you'll find and most gynecologists is sort of, because we're all still in that mindset of once that study came out and it was like, okay, no hormones. And so there still is, you'll find most doctors are like that. I think I'm more kind of in the middle and just really looking at these studies. Like I've looked through them and how they were done, and I see the flaws. And it's not just me. I'm looking, listening to experts on this. That I think we're really realizing that they're not bad, and women shouldn't be suffering. So, for my threshold for starting somebody on hormones would probably be lower than maybe your gynecologist. And so symptoms, I think, can be, just moodiness or just a slight decrease in libido that's not so bad, but it's, it's affecting you. Hot flashes that are annoying, I would say symptoms, but yeah, I don't have a high threshold for starting them.
And maybe even for you to talk a little bit about what they utilized in the Women's Health Initiative. So
Yeah.
it was Premarin and Prempro,
Yeah.
and that's pregnant mare urine.
Yep.
We're talking about bioidentical hormone replacement, and maybe just
Yeah.
talking a little bit about the safety of that, because that's where I think the confusion comes in.
Yeah.
What they were looking at is very different than what we're using now.
Yeah, so Premarin is pregnant mare's urine. That's where it came from. That's where the word is from. So it's an oral estrogen. There's basically 3 different types of estrogen. There's estradiol, estriol, and estrone. And the estradiol is like the most abundant. And estriol is probably maybe has some more benefits, but it's a very mild estrogen. And then there's estrone, which is probably not as safe. So most commercially available ones are estradiol. When they compound, you can add estriol, so you have kind of that probably safer estrogen. And we kind of avoid estrone. But the Premarin not only it comes from pregnant mares, so it's not bioidentical at all. It's very different from our own bodies, and it also has some estrone in it. So it had this sort of cancer-causing, that we knew that estrone wasn't good, and
there's about 16 estrone chemicals in Premarin, and I would never recommend that.
Yeah.
Definitely.
And then the progesterone that was used was a progestin. And there's chemical differences between progestins and progesterone. So progesterone is what we make, and that's the natural progesterone. And progestins are synthetic, and if you look at a graph of all the different things, like progesterones lower the cholesterol, progestins raise them. They have all these sort of opposite effects. They're not really that similar.
The only benefit, right, is that it actually helps the uterine lining.
Right.
That's about it. Otherwise, progestins are not the drug of choice for sure.
Yeah. So that's what they used in that study. So that's a big part of the issue. And not only that, but also just when you look at the data itself, it really didn't increase the risk. Even with the Prempro, it was it barely increased the risk. So it would be nice to have another study done with bioidentical. There are other studies. It's great. There are other studies now. It would be nice if there could be a huge study like that,
Right.
which is very expensive. But there are other studies out there with safer
Just to
hormones.
address her concern about your doctor or gynecologist, and they tell you, no, wait, and you have other ideas, other thoughts because you did your research. There was this one patient that came to me crying, and she said her doctor told her, read a book, there's nothing I can do for you. Just read. Take some supplements. I don't know. This is menopause. So I said, you know what? Divorce that doctor. Find somebody else because you really need to take care of yourself, honestly.
I just don't understand why there's not a study, and why aren't there more, why don't we know why hot flashes exist? Why isn't there, more money, focus, et cetera, on, figuring this figured out? I'm just curious. Obviously, this is great. Thank you.
Still a man's world.
It really is a disservice to women, I think.
Yeah.
It's a big disservice to women that we're not looking at that. And I know our company, our CEO of our company, her name's Terry Weber. She's a breast cancer survivor. And this is a mission for her. This is a mission that we don't lose a generation of women, because we did after that study. Doctors stopped dosing hormones. They stopped giving them in their entirety, and we lost a whole generation of women. Deaths were so much more than they were prior to that. And we just can't allow that to happen again.
Yeah, and the sad part about that study is they didn't even screen the patients who were smokers, how are they eating, what, they didn't even screen them. They just said, here we go, let's have this study done, and it's just a fiasco.
Christina.
So there are so many different ways we can optimize our hormones. How do we know, we're telling three different forms. How do we know what form is best for us? Is it a personal choice? How do we get started?
Yeah, I mean, I think the best thing to do is to go to a doctor who's comfortable, with hormones and with testing hormones, whether you're going to take them or not. Maybe the end result is you're not going to take them yet, or it's not time. But just get them tested. And when you test hormones, you're not just looking at your estrogen and your progesterone and testosterone. You're also looking at your thyroid, and you're looking at your adrenal hormones, and you're looking at all of that because they all work together. So having them tested, and not only looking at the testing is important, but it's also your symptoms and where you are and what you're experiencing. So someone needs to kind of put all that together and see where you are with that. Yeah.
I've heard about people getting B12 shots. What are those?
Yeah, I mean, B12 is a lot of women, everyone, a lot of people are low in B12 because it's absorbed in a really small area in your small intestine. So there's a lot of absorption issues with it. So people tend to be low in that, as well as the other B vitamins that we kind of forget about that, and we do a lot with B12. But people will use it if they're low. They'll take it often for weight loss or for energy. A lot of people say they feel a lot better. So I'd say it's just a common vitamin that is low, and then they also there's like DNA or gene, what we call SNPs, where some people have what's called an MTHFR. People talk about that a lot, where they can't break down their B12, so they need to have them in a methylated, like already broken down form.
That's
So-
important because if a patient doesn't have that genetic defect, then they shouldn't be taking methylated B12. Okay, so they should just take a regular B12 because it could interfere and cause a lot of side effects because the methylated form is the most absorbable form, right? So if you have like a gene defect, you need the methylated B12 in order for it to absorb in your red blood cell versus if you don't have that gene defect and you take that methylated B12, you're going to get too much into your blood cell. And this is what I've seen in some studies. So that's why they strongly urge the patient to find out, do you methylate, do you not? And could you also find out, instead of doing the MTHFR, even the homocysteine could kind of help figure out that level? Yeah.
Yeah, although some people have normal homocysteine and they still have the
Yeah?
MTHFR, I find,
Okay.
yeah, they may be already supplementing.
And just for the group, can you talk about what homocysteine is and why that's important? Because I can see people
Yeah.
not understanding what that is.
Yeah. So homocysteine is a kind of a biomarker. It gets elevated with low vitamin B6, B12, folic acid, so basically B vitamins. And when that homocysteine is elevated, that can lead to increased risks for heart disease and strokes, diabetes. So it's a blood test that's sometimes tested. We do it more in functional medicine. It's not always tested if you go to your doctor and you have a physical, but it's a nice one to look at because it's a sign that those levels may be low.
Do you test the MTHFR on all your patients?
I don't always do MTHFR. I mean, sometimes I'll talk to the patients about it, that the insurance doesn't cover it, so that's been an issue. In my previous practice, that was probably more of an issue, but it still is. So we do sometimes, not always.
What are some of the signs that someone might have the MTHFR gene? Like, for instance, they don't sweat normally. That's one of them. What are some of the other things you might look at versus taking the blood test?
It would be hard. I would say it would be hard to diagnose it based on symptoms because probably those symptoms would overlap with so many other things.
true.
But yeah, I mean, they might be tired. They might have other nutritional signs of like nutritional deficiencies. Their skin might not, their skin might kind of look sallow, and they may have, I think of fatigue is probably a big one, just with the deficiency. So when we test the blood, so before you go on hormones, really, I think blood is fine for checking your hormone. Like, you don't have to do saliva or urine. The only times I would do a saliva or urine test, or if somebody is on hormones, specifically the creams, where they kind of get into your bloodstream, but then they're out and they're in your tissues mostly, and you just don't really pick it up as much in the blood. But so what you would test for hormones, you asked what you would test, right?
When you go out initially to your doctor and you say, okay, I want to be tested, I want to know what my level is, where am I, what should
So the doctor should be looking at the sex hormones, which are the estrogen and progesterone and testosterone. Also FSH and LH, which are the pituitary hormones that will go up when you're in menopause. So the FSH we see go up, and it hits to a certain point, and you can say, okay, it looks like menopause now. And that's the one that can be normal, and then in a woman who hasn't had their period in 2 months or so, and then all of a sudden the next month it's super high. So we look at the sex hormones, and then we'll also look at the adrenal hormones, which are like cortisol and DHEA. We will look at the thyroid hormones, and there's a whole bunch of thyroid hormones, and that can also detect if there's any autoimmune. I think Dr. Lovely was talking about that, the TPO antibodies. So you can look for autoimmune, which would be like Hashimoto's or Graves' disease. That would be kind of a comprehensive hormone panel. And then you're also, I look at the vitamin levels too, like we were just talking about with B12, which is often low, and you can get really in depth with that. There's sometimes I'll use outside labs that will test a whole bunch of different vitamins, and we'll do zinc and copper and look for deficiencies in those. And then vitamins, supplements. There are some, and it really varies so much. It's so individual with the person and what they're experiencing. But ones that we often use are definitely the B vitamins are important because they're part of what we call methylation, or they're basically like they're like enzymes for all these other processes in our bodies, and we need magnesium, and we need B6 and B12. Magnesium is huge. I use that a lot. Omega-3s, which you get through fish. They're the anti-inflammatories, but most people are actually low. We do some tests now where we test omega-3 levels, and I'll find most people are low. So I have a lot of people on omega-3s, good probiotics. I say those are sort of the top ones, but it really depends on the person. Yeah, vitamin D, definitely, right.
What are the good probiotics?
So I like different ones for different things. Like if you're going to go on an antibiotic, there's one called Saccharomyces boulardii, which is actually a yeast. It's not most probiotics are bacteria, but it's a good yeast, and it doesn't get broken down by the antibiotics since it's not bacterial. So I like that one. There's different lactobacillus strains that are good. For women, I like there's Lactobacillus rhamnosus and reuteri. Those are often good for preventing like yeast infections and UTIs. There's a product called Culturelle for women that has those in it, and one called Femdophilus, which is by Jarrow. Those are the ones that I like a lot. Just you have to have a lot, like billions of bacteria in there. I don't know, Rosella, what you guys like at Rye Beach?
We have a few different lines for probiotics. So depending on what you're using it for, we would give you some advice as to which one you would get.
Probably still in perimenopause, on birth control. Would you ever test their hormones? I know obviously there's some hormones are being controlled a bit, being on birth control, but can you if you're still deficient of certain things, can you throw that in? Would you ever test them on that, or do you have to be completely off?
You can test when you're on the birth control, especially like if you have that not continuous type, so that you have that your placebo week. Yeah, you could test in that and get an idea. It's going to be a little different still because you still, their hormones are not completely out of your system. They're sort of, when you're on the birth control pill, the hormones are kind of taking over and sort of controlling your cycle. But I would definitely look at the other hormones too, and the thyroid and the cortisol. I would definitely take a B vitamin when you're on a birth control pill because it can deplete the B levels. Like a B complex. Yeah.
Well,
yeah.
All
the B's.
Yeah.
I know. We should have that.
I think the B vitamins can get confusing. Did you all really understand, or would it be good for her to review that once again? Because you look like maybe just to kind of revisit.
What she's talking about is the methylated B vitamins. So it's almost like they're already broken down for you. They're methylated. Like methylation is something that you need to do with your B vitamin with yourself. But if you have a gene abnormality where you can't methylate, we were talking about that. It's called MTHFR. There's other methylation issues other than MTHFR. It just gets a lot of attention and focused on a lot, but there are other ones too that can interfere. If you have one of those, you might not break it down as much. You can test for it. You can test for MTHFR, but you can also, if you're somebody who just is often low, like I'll find people, like I like their B12 to be over 400, even though the lab says, like Quest says it's normal, I think if it's over like 250, but that's really low. So if I see somebody who's chronically low and I know that they're not a because if you're a vegetarian or a vegan, you're probably going to be low because that's where you get most of your B12 is from animal meat. So with vegetables too, but a lot of it in meat. So if they're they're getting foods that have B12, yet they're still always, and I see them consistently every year, they're always running low, I'll suspect they probably do. They either have a problem absorbing it or they probably do have an MTHFR. And I probably would have them take methylated B vitamins and then recheck, because what Rosella was saying is you don't want them to be too high either. Like they may just, when they're methylated, they just have you don't want to have a ton of B12 or other B vitamins. So you kind of want to recheck it. Does that answer your question? Or just add more confusion? Yeah.
So I think I understand that you would have your gynecologist run a lab for the sex hormones and that sort of thing. Would you have to specifically ask them to run labs on the thyroid levels and the other thing, the adrenal levels? Do you have to ask for that, or does that get run in a typical?
It's probably not going to get run unless you ask. And then there are different degrees. So there's, as functional medicine practice, so I'm an internist, I do functional medicine, and I do a lot of those tests. I will say, coming from a conventional, I'm still in a conventional practice, but working with most doctors are more conventional and won't do as much of that. They might, if you ask for thyroid, they'll probably do one test called a TSH, and they may not do much more than that. And adrenal, they'll be like, or they might look at you like, what are you, this is kind of crazy stuff, we don't do this. So it's a little tough sometimes when you're talking to your doctor to delve into that you can kind of gauge, I guess, and see how receptive they are to it. But they may not be as open to it. They may just say, that's not what I do, you might need if you wanted to do more of this, you might need more of like a functional medicine doctor to do that,
Yeah, I found that too when I help patients and they ask me, could you please ask my doctor for blood work, and and I'd fax the doctor and they'd say, what's this? We don't do this. I don't even know how to interpret it. And I'm like, oof, that's a tough one. So I asked the doctor, do you mind? I can help you interpret it and help the patient get on a plan. If the doctor's open to it, great. If not, then I would definitely refer to someone else, especially if you're interested in checking all these different blood tests. And, I think it's important that you do your homework, really. Find somebody else that can help you.
And as a patient, right, it's this what they specialize in, right? So an OBGYN is going to specialize in something different than autoimmune disease or problems or these types of symptoms that women are having. So the benefit of going to a functional integrative doctor is they're literally like forensic scientists. They say, Sally, you're at this point in your life. How did you get there? And they look at everything. They look at the whole picture. It's not just prescribing a medicine for you and sending you off your way, which is why I went to a functional integrative medicine doctor, because I was getting that sort of mainstream medicine effect. And It's really, prescriptions are a one-size-fits-all. Doesn't matter your weight, your age, your sex, your health history, or, it's a shame because, a prescription of the same dose for everyone doesn't make sense. So when you go to a functional integrative doctor, they're all about individualizing the dose for you specifically to make you feel better. And that's why it's so important to see someone.
And you could still see a GYN for the
Sure.
exam and everything else that's
Absolutely.
a GYN affiliated, but see the other doctor for everything else.
The other things.
Yeah, a lot of times I end up kind of working with the patient's GYN, that people say, well, I'm an internist and I'm, prescribing, if I am prescribing hormones, like should that come from a GYN? Should that come from your internist? I think of it as the internist is kind of looking at the whole body. And so we work with hormones too. And I will often talk to the person's GYN, and it can get a little, like, I don't want to be stepping on their toes, so I might say, hey, are you okay? Your patient really wants to start hormones. I do a lot of bioidentical. Would you be okay? Do you think the patient is a candidate for that? And I look from my end, and we kind of work together to do that also. So, yeah.
What is vaginal ablation?
That's when women have really, usually during perimenopause, when your periods are, some people have really heavy periods, and it's a procedure where they go in and they kind of, ablate the lining of the uterus so that you don't get a period anymore, and it kind of puts an end to that. Yeah, I don't do it as an internist. I have patients who've gotten it done, and I think it's basically safe. There's some risks with it. There can be blood clots during the procedure, but that's a low risk. Afterwards, it usually works. It doesn't always work. That's the only thing. Sometimes they still get a little period. They're generally lighter though.
And that's through OB/GYN?
Mm-hmm. Yeah.
I'm still a little confused. Are hormone replacements recommended during perimenopause at all? Because I feel like I thought that was the time when you're going through all those symptoms, and then once you reach menopause, then you're kind of, whether you're taking hormone replacements or not, your level. So,
Yeah.
From what you said, it sounds like you don't do any anything during perimenopause.
I personally don't usually do much during menopause. Like when they're still getting their cycle, I kind of let them get their cycle, and I'll use other things to help with the symptoms. And I generally start once they haven't had a period. I don't necessarily wait a whole year. It might be if I see the blood showing that they're definitely, their FSH is high and they look menopausal and it's been 6 months, I would probably start it then. There are some doctors who will start early, but you're still getting those symptoms even after you don't have the period for the year. That's the thing. It's the symptoms are still going on then. So people generally still want hormone replacement then.
But so not much during perimenopause. There's not much.
If you're
recommendations for that period?
I don't usually, because I feel like they're still cycling, and you don't want to have them on an estrogen, progesterone, testosterone, so that they're not getting their period. And I just think they kind of have to go through that a little bit. But like I said, there are doctors who will prescribe during that time. I generally wait. A lot of times GYNs will do will put women on a birth control pill at that time. You'll see that. Your periods are crazy and just go on a birth control pill. They will do that sometimes.
And for us, it's we manage the symptoms. We don't dose estrogen or progesterone for someone that's perimenopausal. It's testosterone.
Yeah. Can you think of anyone? Because I
You.
listened to it. Thank you. I didn't write a book though. I wish I did.
Suzanne Summers,
yeah.
she has a whole line of books that might be interesting, right?
She interviews a lot of doctors.
Yeah.
Yeah.
I say, listen to Fiona. Go on, Bring On Your Mother's Medicine.
Yeah, so thyroid is an important, that's a gland that controls, we think of it as controlling your metabolism. Thyroid levels, often, because it's another hormone, it can be impacted by menopause too. And sometimes women will have they'll go into a hypothyroidism during menopause, especially, but it can happen at any time. And sometimes it's autoimmune, so we get Hashimoto's and Graves'. Usually it is autoimmune. And that the symptoms can kind of mimic, they're very similar to symptoms of menopause. So people will be tired, they'll be weight gain, maybe hair loss, dry skin, depression. So a lot of the same symptoms. So it's really important to test for that too at that time.
I just wanted to mention another doctor that has been writing books on menopause, and we work with her. She works with Compounding Labs, and she's amazing. Her name is Dr. Pam Smith. Can't remember the name of her newest book, What You Can Do About Menopause, something like that. Yeah, so she's pretty good.
Do you guys know that doctor who works with essential oils? She's big into using that to help manage menopausal symptoms. She's more like Dr. Dio.
Like a naturopath?
Oh, she's the one who's speaking, isn't she the one who's coming in January?
Oh, Dr. Katie?
Oh, no.
Snyder? basically talking about how it's symptom relief more or less, but especially for us in perimenopause, it's been super helpful to me to use some of those essential oils, which, as you know, go straight.
That's right. A lot of naturopaths do use that type of modality, and it does work.
It really does help, especially with the hot flashes at night. I have the roller ball of the peppermint, but she recommends 4 essential oils in a roller ball. It's very effective.
You all, in your gift bags, Pray Beauty has these fantastic, have you tried it yet? I need to try one right now, but it's got the roller stuff and the cream, it is, you're going to feel great.
How much of this is genetic? Like, are we like our moms and we're going to have the exact same experience they had, or can we be on a different path?
I think it's a lot of genetics, but it's not completely. A lot of it, I would say maybe half and half genetics, half lifestyle. You know, if you're definitely can be better for people who are. I was going to say like eating healthy and exercise, but not necessarily. I mean, you can be doing the healthiest and still have horrible hot flashes and mood swings. So there is a big genetic component to it also, for sure. Yeah.
This is a dumb question, but what is a functional medicine doctor?
Actually, a great question.
Yeah, no, it's not a dumb question at all. So, but the idea of functional medicine is getting to the root of the problem. So if somebody comes in and they have a bunch of symptoms, instead of kind of saying, oh, you're having heartburn, let's give you Prilosec for your heartburn. Oh, you have high blood pressure, let's treat the high blood pressure, and everything is kind of compartmentalized. You're putting it all together and you're saying, well, this person has this symptom and this, and they have high blood pressure. And could this be, what's the underlying issue that's causing these things, and how can we treat the underlying cause, which will then help all of those symptoms as opposed to treating them all separately. That's kind of the main idea of functional medicine.
So
Sure.
it's a very small pellet that goes under the skin. It's either testosterone or estrogen or both, depending upon where you're at, be it perimenopausal or menopausal. So we treat patients from when they start seeing symptoms. So as early, like I said, with men in their late 20s who are low in testosterone, women are low. We lose our testosterone at an early age, and we continue to lose our testosterone. So for instance, before I got my pellet, my testosterone was 0, actually undetectable, and my estrogen was really, really low as well. In fact, it was undetectable. So at the time that I was getting the pellet, I had nothing in my system whatsoever, and I was feeling pretty horrible. So what it is, it's just it's the pellet is inserted under the skin. So it's right in the hip area, right in the upper buttocks area. And it just sits there, and then based on your cardiac output, it is absorbed into the bloodstream. And what's nice about that is that it bypasses the liver, like they have both talked about the importance of that. And then, so it's absorbed into the bloodstream, and it ebbs and flows with your daily activity, just like testosterone and estrogen do naturally. So when you're working out and you're active, more testosterone and estrogen is going to be absorbed into the bloodstream because it's all based on cardiac output. So our capillaries form around that pellet, uptake it into the bloodstream. That's how it works. But at night when we're at rest, not a lot's being absorbed because we don't have a lot of activity around that. So as you're more active, more of it is absorbed into the bloodstream. And then for women, they get pelleted it lasts about 3 to 4 months, and for men about 5 to 6 months. So the nice thing about that is you just place it in the hip and you go. So for me, and this is just my experience, I used patches, pills, creams, etc. And the problem for me was remembering where to rub it in. I didn't want to get it on my children or my dogs, that type of thing. So for me, the pellet, I'm busy and I travel, it's easy, it gets placed there, and then I don't have to worry about it. So that was really nice for me. It provides a steady state of hormones as well, and that's really important too, that we get the natural steady state as much as possible, because it's all about balance, right? We want to be balanced. We don't want to get too much of anything or too little of anything. So that's how the pellet works. Do you have, what's that? No, we treat, we have patients as early as late 20s for men. We give them testosterone. Women, we do pellet with testosterone prior to menopause. And then we do, for women post-menopause who have a uterus, we do estrogen and testosterone as well. So we like to treat the symptoms, and when someone starts having symptoms, they're probably really low in testosterone and estrogen, but we do the same blood test that Dr. Kraus does as well. We look at everything. We look at that whole same panel, and we say if your testosterone is undetectable or very low for where you should be, then we'll supplement it with testosterone.
But does this kind of counteract each other? Because you said that you don't prescribe hormones while you're still cycling, but you say that the pellet works. So I'm just trying to figure out, is it the same, is it different?
Yeah, I don't at that time, and she's saying you guys give estrogen
Testosterone.
and just
Testosterone
testosterone.
only.
So testosterone is kind of different from estrogen and progesterone in that it's not so affected by the ovaries. So you might be low during, perimenopause, so they'll give it, and then you just don't want to give estrogen while you're still cycling, because you don't want to because a lot of times when you're still cycling, the estrogen is actually really high at that time until it drops. So you don't want to add more at that time.
And isn't it true that most patients on the pill will decrease testosterone levels? So a lot of patients complain about loss of libido and vaginal dryness, women in their 30s and 40s. So yes, you'd want to give that patient testosterone if their levels are really low, and even something for vaginal dryness. It doesn't have to be a hormone. It could be hyaluronic acid, which is an amino acid, and it's very mild, and this is the things that I would recommend.